Go ahead and get started. Our next visiting professor, next in our visiting professor series is our visiting professor for community and wellness. It's a long-time Cavalier, but I'm going to have Dr. Dacus, our vice chair, introduce Dr. O'Day. So please, everyone, sign in, get your food, and let's get going.
All right. So this is year 4 of our lectureship, which has changed names, but the meaning's still the same. We like to bring someone in who maybe is unrecognized in orthopedics, whether that's because of demographics or gender or whatever, or location. And so we're not disappointed in Dr. O'Day. She's very familiar with UVA. She went to undergrad here, finished in 2007, worked with sports medicine, so knew Dr. Dita from way back then. Originally from Chicago, and so went back there for medical school. And when she applied for orthopedic residency, Dr. Carson at the time was working really hard to get her here. And I was program director at the time. He was like, "We got to get Gabby. We got to get Gabby." And I was like, "Do what you can," man. And then she went to Carolina. So he did not do enough, clearly. From Carolina, she went to HSS and sports medicine fellowship, and then has continued on doing sports medicine. Went to South Carolina for 4 years. Three and a half, and realized South Carolina was not the place for her private practice group, but she was really interested in academics, and so HSS opportunity opened up, and there she is. So it's year 4 at HSS. Lives in New York City, is married with a 2-year-old, and doing all the things. Team doctor for the New York Liberty. Must have been pretty fun for a championship to kind of be there for that. Has been team doctor for Iona and Clemson and others. Well published, over 100 publications. Is an expert shoulder arthroplasty, revision shoulder arthroplasty, etc. Does knee as well. Does not do hip. So we're really excited for her to be here. I think her talks today are going to be very informative and helpful to all of our residents and helpful to our faculty fellows as well. So please welcome.
I'm very excited to be here. This is, every time I come back to Charlottesville and UVA, this is, it's a little bit feels like home for me. So this is a huge opportunity. I'm very excited. So thank you guys for having me. Hopefully you like my talks, 2 45-minute talks. So thankfully there's a bottle of water here, and we'll take questions in between. So my first talk is this one's pretty personal to me. So it's called Operating with Insight, Performance Feedback and Mastery in Surgery. These are my disclosures. Get them started here. And so, Dr. Dacus gave a little bit of his introduction, and so I'll tell you guys a little bit about myself as well. So I was born in Nigeria, actually immigrated here when I was 4. I'm the youngest of 4 daughters, and when you're youngest, you're told to be seen but not heard. And growing up, I was always science-minded. I was lucky my mom has a PhD in organic chemistry. And I attended a STEM high school as well, Illinois Science Academy. I'd say my 4 years at the University of Virginia is some of the 4 best years of my entire life, with not one kind of bad moment in 4 years. And that's why I always have a soft spot for Charlottesville and UVA, and that was actually also my first exposure to orthopedics. I was a sports medicine kinesiology major at the education school, and I was an athletic trainer for about 2.5 years. So I spent a lot of time at the McHugh Center, and I'd see the orthopedic surgeons walking around and be like, "I think I want to do that." They're the ones who are making all the decisions. I like that. And actually, I got academic credit for shadowing Eric Carson for like 8 years, so he gave me an A, thankfully, so that helped my GPA a little bit. And I went into orthopedics wanting to do sports medicine. So I attended Rush Medical College. That was my first exposure to orthopedic research, and that was with Brian Cole. It's my first opportunity to do a podium presentation at AUSSM as an M2. My residency was Carolinas Medical Center, Ortho Carolina, and I was there from 2012 to 2018. Keynote, I was the first Black woman in the program. I did a research fellowship year, which is kind of built into a 6-year curriculum, similar to what you guys have. And we did a lot of talks as residents. We gave grand rounds as residents, hour-long grand rounds twice a year. And so one of those things where you just kind of get, and you pick a topic that's interesting to you and you run with it. And so, my first couple of years, as a PGY1 and PGY2, my first goal was learn to be a good doctor. And then goal 2 was learn to be a good surgical assistant. And then there's a little bit of a pivot that you make as you progress in residency that, I felt like, in that place, how do I pivot to now being a good surgeon? And so that was the initial spark for one of my grand rounds as a PGY3, which is, troubleshooting the resident evaluation. And part of it was some of the feedback I was getting. And I was asking, how do I get better? How do I, be a better surgeon? How do I be a better resident? People was like, you just need more reps, or you just need to be more confident, or sometimes it's like, hey, your evaluations don't really match what the attendings are actually telling me. So that's where paranoia was setting in, which is being told, hey, you're fine, and then behind closed doors not hearing kind of the nitty-gritty of how to be better. And so that's where I really started to have a little bit of a loss of my footing and felt like, I no longer have a solid sense of self or understanding of, who I am as a fledgling surgeon. For me, I started leaning into a lot of books to see what helped. Chris Amott's book was very helpful for me. That was skill. I read some books about confidence and, somebody who's actually very introverted, trying to understand how can you be quiet but still have command in the room. And so, those are things that, initially set that spark of, how do we really think about giving somebody feedback to improve? And then, as a PGY4, things were rocky, meaning that I felt like I was getting my footing surgically, but now, I was also being told, hey, you operate like you're looking over your shoulder. I'm just scared. Didn't want to make a mistake. Just wanted to kind of make sure that I was going to be as excellent as I could. And then also being told, I was understood myself a little bit better and saying, hey, some of the reason I don't kind of take command is because I'm more introverted, so it's hard for me to kind of speak up. And I remember attending telling me at the time, said, you can't be an introvert, surgeons aren't introverts. That was his response to that. I was really pissed about that. And so actually I decided to get my grand rounds that year on surgical personality. And these are some of the books at the time that I was reading, which was Strengths Finder, just an excellent book. I strongly recommend it. And then The Subtle Art of Not Giving an F, which was a great book to really help me kind of pivot. And, at that point I was thinking about, I was starting to internalize some of those shortcomings and sort of lost sight of, hey, how have I progressed? I'm a successful PGY4. I feel like I've made significant progression as a surgeon and as a doctor, but I kind of lost sight of that. And then when I was PGY5, this was after I matched at HSS for sports fellowship, then I started, understanding how to lean in my strengths. And so for me, that's organization, being more systems driven, quiet mental rehearsal. And then, I had electives at that time that were focused on disciplined individual practice. We actually had opportunities to spend a month at Fort Bragg in Fayetteville, North Carolina, which was a really profound experience for me, particularly as a surgeon, in large part because I was working with, primarily sports-driven cases, but I was also alone. These doctors didn't know me from Adam. They just put me in the OR by myself, and I just scoped every day for a month. That's all I did. I ran, came on base, operated, went home. And, I loved it because it was an opportunity to really kind of hone my skills without thinking about, hey, what does this person think about me from when I was a PGY2, or, how am I progressing and how do I compare against my peers? And so it really kind of helped me kind of realize, hey, I can do this and I can do this really well. I just need to be in the environment that allows me to do that. And so in sports fellowship, I went to hospital special surgery, and also I did about 2 months post-training, fellowship training in shoulder surgery with, fantastic French surgeons, Philippe Colin, as well as Lionel Nated in Lyon, and then Pascal Ballo as well. And in sports fellowship, I really kind of found my footing. And I went in there, and if you've ever been at HSS, we love HSS, and we expect a lot from our fellows, and we expect a lot from our faculty. And so I was put in a position where people said, well, if you're here, you're obviously great, so show it to us. And so that was an opportunity for me to really kind of, flourished in a way that I didn't feel like I felt emotionally like I could as a resident. So my first years in practice, so I was actually in academic practice at Prisma Health Upstate in Greenville, where one of your alumni is now currently. She's taken it from my previous job, Alyssa Altoff. But I was in a rural practice, high manual labor population, did sports medicine as well as general orthopedics, and then was building a complex reconstruction practice in shoulder. I was also a team physician for Clemson University. And at that time, that's when I really started to lean in a passion project, going back to studies looking at performance and personality. And so I started what's called a post-study group. It was profiling orthopedic surgery trainees. We had 11 sites, and this became a little bit of precocious leadership because this was 2020. This was my first year in practice. We had time, right? I mean, we were usually shut down a lot, so I had time to kind of build this consortium to look at different performance metrics in among trainees. And then I did pivot and return to HSS in the spring of 2022. And my clinical practice is specializing primarily in complex shoulder surgery. I also do a little bit in the arthroscopy and elbow tendon surgery. I'm a team physician for the New York Liberty and the Brooklyn Nets. And I came in kind of recruited to be associate fellowship director, and then I took on the role as the fellowship director of our sports fellowship as of this year. And so, long story short, this has actually been an evolving path that has gone on since I did the North American Traveling Fellowship in 2022. And so some of these slides date back to some of those initial grand rounds I gave as a resident. And then some of these have continued to grow as I was in my practice as a fellowship director, also with my post-study group, and really just trying to conceptualize how we think about, performance and optimizing performance. And ultimately at the core, this is a talk that is yearning to understand how we achieve competency and mastery in orthopedic surgery. Obviously, the disclaimer, I'm only 7 years into practice, so I consider myself a highly competent surgeon, but I could not say that I have absolute mastery as a surgeon. And I think all of us feel comfortable saying that we really can kind of know as surgeons. And so, what's the definition? How do we define a competent surgeon? I define it, we think about precision, so they take pride in their work, they don't cut corners. Decisiveness, you make thoughtful decisions with the best available information. You're efficient, to move efficiently without wasted steps. Flexible, aware, so take essential risks, but also recognize and avoid unnecessary risk. And then also there's a component of leadership, which is communicate clearly and effectively and support and encourage success of the entire team. But how do we learn that? How do we learn to be competent surgeons? So if you think about the stages of learning, we've all probably seen some element of this. There are really 4 stages of learning. There's that stage 1, which is unconscious incompetence, which is blissful ignorance, right? Which is we don't know what we don't know. And then stage 2 is conscious incompetence, which some people will call, the pit of despair, which is, we have awareness at that point. We begin to realize how little we know. Stage 3 is conscious competence, where we can perform a skill, but it takes attention and concentration. And we achieve that in a skill if we can perform it consistently at will. And then unconscious competence, and that's where the skill becomes so practiced that it enters the unconscious part of our brain and becomes second nature. And we can do something effortlessly without thinking about it. So competency is a word that we've seen and heard a lot, particularly in any ACGME setting. Because we talked about competency-based medical education, and in theory, how the ACGME is defined that is its competence is more broadly defined. It's a mix of knowledge, skills, and attitude. It's outcomes-based and not process-based. And so it's observed competence. You have a teacher who is observing a trainee, and it's not assuming competence based on length of experience, and it can be, in theory, time independent. So it shifted away from kind of fixed time to say, hey, here's 5 years of training, you'll figure it out at the end, to more other metrics that can be achieved over time. And so in the US, for graduate medical education, it's this hybrid competency-based and also time-based education. They created the core competencies in 1999, which talked about these, which shifted to that competency-based educational standards. But they also still kept the time restraints. So they still kept, hey, you have to do all this within 5 years. And the challenge is, as many people in this room know, is that, there's less time for observation. There's less time to meet these competencies. Work hour restrictions have been in place since 2003. So we're actually going at 23 years of those restrictions. Our whole generation has been through these restrictions. And what that did is that limited, duty hours to 80 hours. And really the difference is previously, residents would work up to 110 hours a week. And so you have that difference over the course of 5 years, and that's about 5,800 hours, about a year and a half less training time than people who trained prior to the work hour restrictions. And so fewer work hours, that impacts perception of how a resident is competent and our trust in our residents, because more time with attendings, we know, contributes to perceived trustworthiness. And so residents who log more hours tend to have higher scores and overall evaluations of their competency. And they tend to have higher scores on their evaluations of their technical skills, in large part because with more time with attendings, there's more trust. And with more trust, there's usually more graduated autonomy. And so, studies tell us that with that, skills autonomy is dependent on an attending's familiarity with the resident stage and training. And so that lack of acquaintance can contribute to fewer independent responsibilities and more scrutiny. And, if an attending knows a resident well, then they're usually more readily willing to give them autonomy in a case. And so that has a challenge when you have less hours with residents. Also, some challenges that we saw with graduate medical education and competency-based training is, vague assessments, right? People are judged based on categories that don't always seem that relevant. They're on different levels of ability instead of specific skills, tasks, or behaviors. Usually these rating scales from poor to outstanding, which tends to have a huge, end diversion bias associated with it. And then those ratings are completed retrospectively at the end of a rotation. So people are usually basing off that last case with somebody or over the course of the month. And so it's not usually able to kind of pick up, specific issues. And then also rater compliance is a major problem. I'm sure you all know it's very difficult to get assessments over the course of the year from attendings. And, studies have shown that raters are less likely to tell a resident their performance is unsatisfactory or below the expected level, and they're even more unlikely to fail them. And so this study, even as far back as 2004, showed that end of rotation feedback, particularly for surgical residents over 5 years, only about 0.7% of them noted a performance deficit. And those deficiency then only really would come to light at annual evaluation meetings. Other challenges we face with GME is just bias and inequity in training. All of these studies, what do these studies tell us? These look at gender bias, and specifically they look at autonomy in training. And consistently, women surgical residents are afforded less autonomy than men, despite similar technical performance. And if you think that that is a bias that's specific to male attendings to female residents, you're wrong. Sometimes the least autonomy is provided to female residents from female attendings. And so, some of the challenges that we face even in the evaluation of residents is, the core competency committee is also flawed. So when we talk about how we evaluate residents, the CCC committee meeting, it's retrospective. It's usually very non-specific. People offer, very sort of vague details, and it's significant risk for groupthink because somebody say, hey, this resident, one person says this resident is amazing, and then the whole group agrees this resident is amazing. And then you hear, hey, this resident's not that great. They kind of struggle in this case. And then all of a sudden you hear, you're right, I do remember that one case that person struggled. And then all of a sudden you have this huge discrepancy in somebody's performance without specific details, and also a lack of immediate transparency as to what's going on in those meetings. And so ultimately some of the challenges that we face in terms of performance and evaluation is there's really a lack of true time independence, which it doesn't address issues of trust or maturity of a resident. Our competency assessments are vague and subject to end diversion bias. Our CCC committee meetings are subject to potential bias. And again, bad data in leads to bad data out. It also ignores entirely the realm of cognitive factors that can that can affect performance of trainees, particularly for surgical skills. And so, how I describe, GME in America today, if you think about it from an evidence-based medicine perspective, if every resident's portfolio was an individual research study, 5 years of data, we're making progression decisions based on level 5 evidence, right? Retrospectively collected data, outcome measures with limited or unknown validity, lots of missing data, and then conclusions that are supplemented with anecdotal evidence and prone to bias. Not great. So, if we think about deficiencies in resident performance and how people, progress, are we actually, propagating a self-fulfilling prophecy where if somebody has less opportunity to train and learn, fewer hours, they're getting less quality feedback, so now there's less trust, even more less quality feedback, so now they get less autonomy, even fewer quality feedback, so now they have less confidence, and then ultimately that contributes to less competence. Less competence contributes to less opportunity, and we're in perpetuity in this cycle overall. So going back to those stages of competency, really when we think about our graduate medical education for our trainees, GME and competency-based curriculum also just stops right there at stage 3. Is this person competent? Can they do a skill consistently at will? And we completely ignore stage 4, which is mastery. We just want our residents to kind of get through and then leave them to their own devices on mastery. And so for the years, as I thought about kind of how we reimagine surgical training, really want to think about the pendulum shifting away from quantity to quality, and then time and repetition to purpose and precision. And so what does high quality surgical training look like? And to me, it involves cognitive awareness, high quality reps, effective feedback, and also leaning into soft skills development. And so there are different things that can influence performance. There are known cognitive influences to performance that we don't talk about enough. That includes stress and burnout, error recovery, risk tolerance, and stereotype threat. Burnout. I think we've all been here at some point in training in life, and that's just the nature of a very difficult job that we have as orthopedic surgeons. So over half of orthopedic residents report being burned out. And what does burnout mean? That's high emotional exhaustion. And usually the reasons behind these factors, are consistent. High depersonalization, low personal accomplishment factors. And so much of that is related to early training years, unmanageable work volume, lack of program support, lack of co-resident support, inability to kind of take time for self-care. That includes just going to a doctor's appointment, checking in on yourself, exercise. And all of those factors can contribute to burnout amongst residents. And we also know that stress can affect performance. So while there's not a direct link, we know that excessive stress impairs performance. Expert surgeons experience less stress and have less impaired performance compared to junior surgeons. And stressful crises can also impair surgeons' non-technical skills, so their communication, their decision-making. So while there's not a direct correlation, there are at least side correlations to say this can affect performance. Error recovery, and that's something that changes as you progress and have more experience. So this study looked at, surgical errors and how somebody recovered from it. So and they asked the questions, do I feel confident in my ability to recover from minor errors or from major errors? And in general, junior trainees feel less confident about their ability to overcome major errors. And you can see the progression as somebody gets from, red is the ones who are unable to, green is, yeah, I can recover from a major error. And there's a huge discrepancy from junior to senior. And then also risk tolerance. And this is one of those things where it is a little bit interesting when you think about risk tolerance, because it very often gets tied to the question of confidence, which is, if you're willing to take on risks, does that mean you're more confident? But at the same time, sometimes people take unnecessary risk and then you question their competency. But studies have shown that, comfort with uncertainty and the ability to tolerate risk in a surgical field is necessary. So And how does that tie to personality? Are some people just generally, more conditioned to tolerate risk? And when we look at personality, they found that surgeons who are more extroverted, so this is with the Myers-Briggs type index, and more extroverted, more thinking versus feeling types, receiving types, they demonstrate higher tolerance to risk. And those who are more introverted, higher feeling types or more judging types have more risk aversion. And then lastly, the other kind of cognitive factor that may affect performance is stereotype threat. And this is something that is an area of research that I find deeply interesting. We published a study recently on this. So what is stereotype threat? It's a unique psychological phenomenon where perceived fear of fulfilling negative stereotypes about one's identity can impair performance. It's commonly reported in women and in minority groups. This has been looked at every level, primarily from high school through college, beyond. And so how stereotype functions is if somebody is doing a specific task or a test or in their surgical case, and they're aware of a certain negative stereotype related to their identity. So they say, hey, I assume that I'm inferior at this task. That self-perceived threat makes them feel like if I fail at this task, then I'm fulfilling that stereotype that follows me. And then that creates a cognitive block where now they're distracted, they have self-consciousness, they're afraid to have evaluations, so they're apprehensive to ask for feedback. They can have test anxiety, and then there's also then becomes a loss of motivation, meaning, well, if I work hard at this and I fail, it just proves basically that I align with that negative stereotype. So if I just don't try, then it's not because with my ability, it's because I didn't try. And that ultimately can interfere with performance. Stereotype threat has been extensively evaluated among women, and in general, it's somebody's more likely to experience stereotype threat if they're the one or only in a group. They're a token minority, which is usually less than 15% of a minority in an activity, in large part because that increases the visibility of that person and puts them at more risk for stereotype threat. And women, but not men, are more likely to be negatively stereotyped or have lower performance expectations when they are isolated from their same gender peers, meaning that if a woman is primarily in a group of men and they perceive that there's a negative stereotype associated with women, then their performance will suffer. And this has been looked at surgical performance, so this was a study in general surgeons who residents were reminded of negative women's stereotypes, and they were actually looked at an abstract that told them that women inherently do poor at laparoscopy than male surgeons. And what's interesting about this study is when people were provided that abstract, which is a fake abstract, does not exist, when they were asked to do a laparoscopic procedure, the women who had high measured stereotype vulnerability had worse surgical performance. Ironically enough, men who had high stereotype vulnerability, meaning that internalized a perception that maybe men are not as good as surgeons, if they saw that abstract that said women are worse surgeons, they did better. So that's called stereotype lift. And ultimately, when the negative stereotype was removed, where now those men and women were told, actually, men and women have similar surgical skills. They're the same. There's no difference across the board. In that setting, then women were able to recover and perform better, and men performed worse. Think about that for a second. So we looked at this actually. So this is a study that we published last year that looked at just stereotype vulnerability for race and gender among orthopedic residents. What we did find is that if somebody was the most isolated resident, so Black and Hispanic residents had the highest stereotype vulnerability, and that was particularly in the case if they were in the program that they found were non-diverse. Women had high stereotype vulnerability regardless whether they were in a diverse program or not a diverse program. So it didn't change their ultimate stereotype vulnerability. But the most race or gender isolated residents, so residents of color and non-diverse, racially diverse programs, women at non-gender diverse programs had by far the highest stereotype threat risk. And so how does that affect things? So this is a study that Selena Poon just published recently a few months ago, and we look at attrition. And ultimately, several studies have demonstrated to us that underrepresented minorities, as well as women, have higher attrition from orthopedic surgery than the overall resident population, to the tune of almost double. But this study, they looked at if a program had several women faculty or several underrepresented minority faculty, and they found that programs that had below average diversity amongst the faculty had significantly higher rates of all resident attrition, particularly if it were women and minorities. And then residents in above average diversity of faculty representation, this decreased risk of attrition. Can we directly attribute that to stereotype threat? No, we cannot. Those studies are not done yet, but there's likely some correlation in terms of performance if somebody feels that they're alone and they feel that they're at a higher risk of stereotype threat. And so I go back to when I think about when I was a resident, and I look back at kind of what were my 5 years like? What were those first few years for? I say objectively, I'm not a great surgeon. Like I don't know any PGY2 who's a fantastic surgeon in general, but I wasn't. I probably didn't turn the corner until I was a 4. And I think about why was that? And so I look at myself as, as a fellowship director critiquing a junior resident. And at the time, I'd say I was risk averse. So I had fear of failure. I could not error recover at all. I was quick to give back the knife. I was avoidant of exposure, and I had significant stereotype burden as the only Black woman in my program in general. So that meant that my performance was highly malleable, inconsistent. If I was with an attending who I knew believed in my skill set, I could flourish. But if I was with an attending that maybe I knew, I don't know if this person thinks I'm very good, I would give back the knife and my autonomy would be diminished. And that contributed to poor performance in those rotations in general. Pretty high burnout, I'll acknowledge that, particularly as a PGY3. And also, low leadership-based self-efficacy. So I did not feel that I was doing a good job at being efficient and making intraoperative decisions. And I did not feel that I was a strong leader at that point. And so also ineffective surgical preparation, for us, my training, so read. I'm very much a kinesthetic and a visual learner. For me, I'm not a low auditory learner, which we'll talk a little bit about, which means if somebody is talking to me and trying to explain something to me, I have a hard time processing that and being able to be effective, as opposed to somebody showing me directly and then me following up after seeing the experience. These are things that I did not understand at that time as a junior resident. And so when we think about mitigation strategies for some of those cognitive issues, let's first talk about stress and burnout. And so early recognition is important to be followed by early intervention. When somebody has burnout, you want to destigmatize and utilize accommodations and professional resources for them. If somebody's at risk of stereotype threat, or if you have a resident that is at risk, how we found to address this is to introduce the concept to the department, educate faculty about what stereotype threat is and how it manifests in performance in particular. And also, promote an identity safety in your workplace environment. So what has been studied and what's been known that you can reduce stereotype threat, particularly for those who are at highest risk if they're in an identity safe environment. So that can be high representation in that department, but also an institution that values diversity and inclusion. But it can be worsened if there are cues that indicate identity threat. So that's where low representation can trigger stereotype threat. If there is a culture of sexism or racial bias in an environment, that can propagate those issues and affect performance. Understanding to recognize when, risk of threat is worsened. So particularly in higher stress, higher visibility situations, conference presentations, in training exams, the operating room, post-call checkout, those are high visibility performance situations that can increase the risk of exacerbating stereotype threat amongst the trainee. And so those are situations, as long as you're aware of those issues and say, how do we disarm somebody who we know is potentially at risk, a big way to do that is also to, acknowledge that there's a potential stereotype threat, but also provide criticism in a constructive way. And so it's not, don't give criticism to somebody who may be at risk of stereotype threat. It's actually give feedback free of bias that doesn't invoke a negative stereotype. And so, for example, giving feedback to somebody who's not performing at the level that you would expect, that's less likely to trigger stereotype threat, is to say something like, and provide assurance to that person that they're capable of meeting those standards. So saying, I know you can do better than this, as opposed to you're just not doing the job, you're not doing as well as your peers. By acknowledging, hey, I have higher expectations for you, so this is not because I'm coming in with a negative expectation, that allows that person to understand this is about performance, this is not about a continued perception of who I am. And then also kind of understanding a little bit about, there are other influences that can affect performance. So this is where, I kind of lean into the research with the post-study group is better understanding of some of those unknown cognitive influences on performance, like personality, learning preference, and leadership style. And so going back to the post-study group, what we looked at was cognitive processes across all of subspecialty training, and how it impacts performance. How we measured that is we looked at the Myers-Briggs type indicator, the Big Five, learning preference through the VARC, leadership traits through the leadership traits questionnaire and the leadership efficacy questionnaire, and then stress and burnout through the perceived stress and the Maslow burnout index. And so we evaluated residents over the course of 5 years, and we're able to kind of tease out, are there certain things that we pick up on based on both cognitive and non-cognitive processes. So briefly, what the Big Five is: the Big Five is the most commonly used personality assessment in academic psychology. And it looks at 5 specific factors, what's called the OCEAN factors. That's kind of the short acronym. And so that's openness to experience, conscientiousness or dependability, extroversion, agreeableness, and neuroticism, which is emotional stability. And this, it's not necessarily new. There have been, studies over the years that have looked at, surgical personalities and seeing if there are differences. And we found that surgeons in general score higher on conscientiousness and extroversion, significantly lower on agreeableness. But actually, when you look at differences between trainees, there are also some differences as people progress with experience and training in surgery. And so they looked at first-year medical students versus surgical residents and found that surgical residents have higher conscientiousness, and extroversion, a lower openness to new experiences. Surgical residents were more surgically inclined medical students. Both have high conscientiousness, agreeableness, and openness to new experiences. Both have lower emotional instability, so lower neuroticism. Those surgical residents scored even lower on that scale. And so what this study concluded is that there are certain, personality types that may make somebody more inclined to pursue a surgical field, but people can also adapt over time and, become more emotionally stable and less neurotic over the course of training. And so this is one of our first post studies that's published at JBJS last year, and we looked at the Big Five personality traits and burnout, and found that, the vast majority of orthopedic residents have a high openness score, conscientiousness, extroversion, agreeableness, and low neuroticism, which is similar to what we'd see in the other surgical fields. We also looked across trainees. We looked at residents versus attendings and found that when you compared faculty versus both junior and senior residents, faculty had higher conscientiousness. Senior residents versus junior residents, senior residents had higher conscientiousness. When we looked at faculty versus junior residents, lower extroversion. So faculty a little bit more, introverted and more introspective than junior residents. And then faculty versus senior residents, higher agreeableness among faculty. But when we compare it to burnout, what we found is that high emotional instability or high neuroticism, much higher risk of perceived stress, and all 3 facets of burnout. agreeableness seemed to be protective against some of that, so against depersonalization, low personal accomplishment. And extroversion seemed to actually be protective against low personal accomplishment. What was notable, though, is that the female sex was the only demographic variable that was significantly associated with burnout. So female residents still had high emotional exhaustion regardless of their personality type. We looked at leadership traits. So how does leadership development progress over residents? And how does that, what processes can that tell us about training? And so, introverted residents are more likely to perceive themselves as less effective leaders in terms of their action and self-regulation. Male residents are more likely to see themselves as more effective leaders than female residents. And senior residents are more likely to perceive themselves as having greater persistence as a leadership trait or greater resilience overall. What about learning preference? I talked a little bit about how learning style may, affect how somebody trains. We looked at this and found that most orthopedic residents are kinesthetic or experiential learners, meaning that if they see something, they're more likely to continue to do it and do it effectively, as opposed to auditory learners, which we talked about. Kinesthetic learners, so again, that's using all of your senses. That's a hands-on approach, trial and error, real life. This all sounds very familiar to most people because that is what orthopedic training ultimately used to be more consistently, but we still try to demonstrate learning through examples. We looked at learning preferences and surgical preparation and found that in general, the vast majority of orthopedic learners prefer kinesthetic learning styles, but what they actually use. So this looks at, okay, the vast majority of orthopedic residents are kinesthetic learners, which we understand, but what do they use to train? How do they prepare for cases? And, kinesthetic learning styles were the least utilized. So now we're talking about simulation training. So the bottom scale, cadaver training, those are both kinesthetic styles. But the most common being web-based surgical videos, that's a kinesthetic style. So that was both the most frequent and the least frequent used style for training. And so if we're talking about how the majority of residents learn, how they process information, and how they become more effective learners, we haven't really thought about how do we modulate the style of training to fit their learning preference and their learning style. And so we think about getting higher quality reps. How do we do that for kinesthetic learners? And that can be cadaver simulation, arthroscopy simulation, which some we talk about in sports often, video coaching, and then just interoperative reps. And so simulation, what's the role of simulation? For a while, we were seeing lots of studies related to simulation. We still see them trickle in general. And we talk about arthroscopy simulation. We know that, for novice trainees, simulation, low fidelity models like the FAST model can improve basic arthroscopic skills, but primarily just for performance metrics like completion time, task completion, all those things, simple, checkbox metrics, but less improvement on quality metrics like decision making, efficiency. Those are things that simulation is not quite as effective at. When we talk about cadaver simulation, when's the best time to really incorporate cadaver labs and simulation? And the vast majority of studies will show that the best times actually for PGY4s, because at that point they're beyond kind of being an advanced beginner. Their hands are generally sufficient, but they're not quite at the level of competency. And so that may be the time to really push somebody into the level of competencies through cadaver simulation. And that's because cadaver simulation, those are opportunities for solo practice. They're supposed to be dress rehearsals for real surgery, but if your hands are not there, they're not the best, quality reps for somebody that has limitations in terms of their technical skills. Arthroscopy simulation is one we say, okay, well, do we know if that's going to be sufficient? And again, low fidelity models, overall may be helpful to really help somebody outperform a surgical group. But again, that's for specific technical skills, minimizing error, making procedure time shorter, but may not necessarily actually improve quality This is a study I did as a resident where we actually had residents do self-guided learning on a knee simulator, and then we compare their performance on wrist arthroscopy before and after the knee simulator to see is any arthroscopy skill on a simulation transferable. And the finding that we found that was interesting is some of it's transferable. So novices, much better, just to get their hands going. PGY2 residents and 3s, it's slightly worse. And then our PGY4s and 5 residents, it's substantially worse. Like, why? Why would doing knee simulation make them worse on wrist arthroscopy? And part of it is because what's missing is feedback, and that's an important part of quality learning. So surgical reps without feedback aren't useful reps. They're not quality reps. And so in order to make that progression from unconscious competence to say, hey, just the basic hand skills to do I know why I'm doing the things that I'm doing and effectively and efficiently, you need feedback. And so different ways to provide feedback that can include video coaching. We know that this is a study that looked at video coaching and found that it both significantly improved performance and improved the resident's self-efficacy because it allowed for that person to have direct feedback on their performance, on their actual performance that was recorded. And that was found to have both, more long-term behavioral changes than verbal feedback alone. How do we use feedback, however, to drive competency? And so we have to think about it, how do we measure competence, right? So even if we're talking about feedback, okay, what have we learned so far? Quality reps require feedback. They require repetition in a methodical way while understanding how, different performance metrics and cognitive processes can affect performance. But ultimately, the feedback becomes an important part of how to internalize that growth. And so we used to use measures that say poor to excellent, right? And what we probably should be using is entrustability. So going back to, do I entrust you to do something and provide autonomy? And so entrustability scales were built to look at that, to say, in order to allow for an attending to provide feedback in an objective, non-emotional way, pivot to say, do I trust you to perform this task or do I not trust you to perform this task? And that's where, the O score was developed. And many of you probably may not realize that you've used the O score, but you have, and a lot of that is because of KSB. So the O score looks at entrustability, which says, did I as the attending have to do everything in that case? Or did I need to not be there? I didn't even need to be in the room. When I was a resident, we actually looked at the feasibility of implementing the O score. Some of this became then the initial framework for when the board actually at ABOS started using the O score. And we talked about how do you distill this information. We found that in general, faculty are more comfortable giving residents feedback, and if residents are more comfortable receiving feedback, even if it was a lower O score because it was worded in entrustability language, they could receive that information in a more constructive way, and faculty felt more comfortable giving it. So ultimately what we concluded is the best way to provide feedback, so the ideal assessment tool has to be concise, use entrustability language, immediate feedback for the resident to review, frequent, so at least once a week, and then flexible in order of a selection of the procedures outside of the ACGB milestones. And ultimately that became the framework, looking at both the E score, O score, and the P score as a single summative question that's similar. And that's what kind of led down the line to the OP surgical skills assessment pool, which many of you use so far. And then as of this year, I believe, right, I think all programs use it. And so kind of the last thing we want to talk about is soft skills. And because that's one area that I think we still haven't teased out. And so what are soft skills? So that's non-technical skills. Non-technical skills. This is actually something the University of Edinburgh developed many years ago, almost 20 years ago now, which is how to assess decision making. So beyond technical competency, so situation awareness, decision making, communication and teamwork, and then ultimately leadership. And we found that not all of those elements will be the same in any case, but it's something that needs to be trained and taught. And so actually, for me, for my fellows, when I think about giving them feedback as higher level learners who have progressed through residency, and are coming in as consciously competent, but we're really trying to push them towards mastery. I know this slide is hard to see, but this is their post-rotation feedback that all of my fellows get. And so the faculty fill out an O score, they fill out a P score, they fill out the ABOS professional tool, and then they also fill out the NOTS. So the NOTS is asking questions about situation awareness, leadership, non-technical skills. And then overall, the assessments, are they progressing across their fellowship year? And the reason I do that is because for me, and I tell my fellows this, is we know you're competent. You got here, you're a fellow, but how do we push you towards mastery? And you're not going to get mastery by the end of the fellowship year, but how do we set that foundation to say, how do I continue to progress forward and then look towards unconscious competence as an ultimate goal of practice? And what drives mastery brings me back to that question of, what's a competent surgeon, right? So we talked about precision, decisiveness, efficiency, flexibility, awareness, and leadership. And so with our trainees, when we think about how do we demonstrate this as competent surgeons ourselves, I also think about me and my personal practice where I am now, and how do I demonstrate continued learning beyond fellowship trainees. And so for me, that my personal strategies that I utilize now is, still looking at those things. So focusing on leadership. So cadaver course instructor, I'm a fellowship instructor. I also attend cadaver courses so I can continue to learn things new or novel ideas. And that for me speaks to awareness and flexibility. I still use checklists in every part of my practice. And then for me, clinically and surgically, I focus on precision and decisiveness. And those are the things that I want to kind of champion for my trainees. For me, I talked about how mental rehearsal I found was such an important strength for me when I was a trainee. And, and that's something that I continued to grow, in practice. So, as an arthroplasty surgeon, 3D planing wasn't a huge thing back about 6-7 years ago, but when I was in France, everyone planned. So that's where I really learned 3D planning was in my 2 months. We planned every case. We knew what the implant was that we were doing. And so I started doing that as part of my practice to say, how do I mentally rehearse? So I 3D plan every arthroplasty. And then since 2021, I've done navigation assisted surgery. And just briefly touching on that, robotics and navigation is this big wave. We've seen it in the total joints literature, but it is something that we talk about more in shoulder arthroplasty, potentially to improve preoperative planning and accuracy. And, some studies demonstrating maybe lower complication rates, but we really don't have long-term data on that yet. And so for me, this is my life now. This is what I do every week. I have 2 arthroplasties on Fridays. So when I think about how I prepare and plan and to be a competent surgeon, I 3D plan all my cases. So when I think about, okay, for this case, these are the things that I personally want. When I plan on the humeral side, these are the metrics that I teach my fellows. These are the metrics that I follow in order to prepare for a case. And then for me, intraoperative navigation helps with execution because I want my x-rays to look exactly how I planned it. Maybe my plan is bad and I'll find out in 5 years they weren't a great idea, but at least I executed it the way that I planned ultimately at the time of surgery. And what that's helped me is with those challenging cases and is taking a lot of that kind of planning anxiety. So in New York, for example, everyone's small. I don't know why. Everyone has tiny glenoids. I don't know if it's just because we have small apartments, so people just sort of come to that size. So this is a patient of mine, 79 years old, so high stress fracture risk, 4'4", 112 pounds, tiny glenoid. So could I do this surgery without navigating? Absolutely. Do I want to? Absolutely not. Because I want that patient to have the best outcome. I want the x-ray to look exactly how I planned it. And I want her to ultimately be successful. And so for her, I planned it. The implant went in the only 1 to 2 millimeters that it was allowed to go in to avoid an intraoperative complication like a fracture. So that's how my practice has evolved in general as somebody who really started as, hey, I just want to be a good doctor. I just want to be a good surgical assistant to, I want to be successful at what I do. How do I continue to kind of move forward and train? And so it's been a long journey, but when I think about now as somebody who's a fellowship director and what training means for me as a surgeon personally, but also for the people that are coming behind me, the conclusions that I've drawn is that we have to really think about incorporating higher quality reps, teaching and feedback across a 5-year curriculum. Guidance is important. We cannot, abdicate our responsibilities as teachers to just absolutely independent learning. Reliable metrics are important and should be frequent and often. And we really just have to move the benchmark up to not just be talking about competency, but aiming towards mastery at every level. And real mastery is involved in personal insight, which is understanding your limitations as a teacher, your limitations as a trainee, and also thinking about how do we grow beyond our limits. And I think about if we want to continue to change the system, which is orthopedic training in 2026, we have to change about the way we see our learners. What are the roadblocks that they have in general? How do we make 5 years an effective time frame or 6 years an effective time frame for somebody to both be competent and then also continue to aim towards mastery in their practice? And also the way they see themselves. This is a great paper from over 10 years ago now, and it really kind of talked about the remarkable orthopedic surgeon. And so how do we have a quest and continue to quest for excellence, but while maintaining a sense of caring? And the quote at the end is the factor that distinguishes a remarkable surgeon is self-awareness, right? It's the ability to turn relative weaknesses into opportunities for development rather than causes for derailment, whether it's repression, low self-esteem, or sadness. And for me, that's the standard that I set for myself to aim to be a remarkable surgeon, which is to not lose sight of how to be a caring doctor or a caring teacher, but also be able to say, hey, there are things that are continue to be weaknesses, and as long as I remain self-aware, I remain able to progress and move towards mastery. So that's all I have. Sorry, I ran a little bit over on the first one, but thank you guys. I'll take any questions.
Which might not be here.
Any questions in the room?
So that's absolutely remarkable. It's a short career, I guess, of work that I'm sure you're going to expand upon. One of the things that I've been frustrated in the KBS and so forth is that it's a two-way street, right?
Yeah.
I get asked all the time to fill out forms or fill out evaluations when the residents did well. When they didn't do well, guess what?
Nothing.
I get nothing.
Yeah.
So this is a two-way street.
Mhm.
And everything you put up there was about how we as faculty can do a better job on evaluating and providing performance feedback. But it goes two ways. So how do you encourage your residents to ask and speak up and not just send me the cases they did well on and send me the cases where they did terrible? Because you're going to learn more from those cases if you ask for feedback.
Yeah. I agree. It's totally a two-way street. And it is a challenge, right? Like you can't, what's the phrase, bring a horse to water and make it drink.
Right.
I think a lot of it is a culture shift, and that takes a long time. That is a reminder to faculty, hey, you have to probe people to give the feedback, but a consistent reminder to fellows and residents, you have to ask for it. It's uncomfortable, but it's absolutely necessary for you to find out. And I do think a lot of residents are hungry for that feedback, but then sometimes you give it to them and they're not ready to hear it. And that, I haven't figured that one out just yet because, all I can do is flood the zone. That's basically how I see it right now, which is I have my faculty, hey, I need those evaluations on the fellows. And then this year we started doing immediate feedback. So this, and that's been a challenge even still. So I started having them basically do immediate post-operative feedback. I made it low for them. I was like, I just need 2 a rotation. And it's always 9 weeks in, I start seeing the feedback trickle in where they send for evaluations instead of the beginning of the year. And so I do think it's an evolving process to tell people, hey, you have to ask for it. If anything, you're going to learn more from the bad cases. The entrustability language helps because it does allow people to say, hey, by the way, I never give anybody anything higher than a 3. So like, I never leave the room. But I want you to learn about the different metrics that really push, performance forward. The other thing that I think will help, which is coming down the pipeline, and that's kind of my next endeavor, if I have time, is to think about EPAs, right? So EPAs are entrustable professional activities, and that takes a certain task and breaks it down to multiple different parts, and then says, I'm going to evaluate you on your ability to do this part. So, for example, an EPA for, say, the rotator cuff repair would be, I'm going to break down the diagnostic scope. How much can I entrust you to do that? Do I need to be in the room for you to do the diagnostic scope? No? Okay, if I do, what's the reason why I can't let you progress? The decompression, the passing sutures, the ultimate final repair. So it allows you to kind of break down specific tasks and say, what are you going to learn and get out of this? So that ultimately when you put together a whole procedure, that I feel that I can entrust you across the whole spectrum. And some of that is just kind of fundamentally breaking learning down in a way that allows for somebody to learn. That remains a challenge because we all have busy practices, we all try to get through the day. And so focusing on how do I allocate a time, in this case, to a trainee when I've got 6, 7 other cases that need to go, that's hard. I think our learning environment has changed in a way that fundamentally makes it harder for us to give the knife away consistently. And so to some degree, this provides some framework to do that, to say, okay, if we start thinking about EPAs in orthopedics, which anesthesia has been doing it for a long time, there's probably about 10, 15 years of European data, specifically coming out of the Netherlands, where they look at EPAs to say, how do we break down a specific task to say that somebody's competent at this? It has been effective. It's just something that we really have not sort of stepped into orthopedics yet. All right, long answer. It's just my way of saying I don't have the answer to that question. So, any other questions? Yeah.
Gabby, it's great to see your career flourishing after starting here as a student athletic trainer. It's really cool. I think one of the things too, 30 years here teaching, is what do trainees do with the advice that they're giving. And so often I'm encouraging them to spend time with the simulator. And I think it's, there's a little disconnect. When you think about the open skill set that we have so many reps looking at our hands, learning how to use the instruments, how to position your hands, how to make yourself better, right before they're actually graduated towards doing the procedure. Then all of a sudden they rotate to the sports service.
They're starting all over.
Brand new.
Yeah.
Completely different skill set. I'm looking over there, my hands are here. How can we expect them to be good like that? Well, they're, it's different. It's a completely different skill set. And if they're having trouble with basic triangulation and the instrument's crossing, they get frustrated, they get anxious, and down the cascade you're talking about, and they get stuck. And I just, going to the simulator helps overcome that. It gives you time to get those reps to start developing a new skill set. And I offer that so many times, but some residents take that advice, others don't. And the ones that do, off they go, because then they get past point A. So that's the other piece of this. What do they do with the advice they're given?
Yeah, arthroscopy is interesting because it's true. There's a huge learning curve, and a lot of it is with the simulation. What we do know, simulation is good, but you kind of have to be there that first day with them with the simulator and watch them and say, hey, these are the things you got to work on: your triangulation, you're rotating the scope, how you're holding the scope, and then let them, grow with those reps independently, and then check back in even with the simulator and say, okay, let me see where you're at, because you can spend hours on the simulator, and if you're getting the scope upside down, then you didn't learn anything. You just learned in perpetuity to, hone bad habits. And so there's a little bit of some guidance, and that's the challenge is structuring some of those check-ins. And that is a huge challenge I see. There's a learning curve for arthroscopy. It's very different than open surgery. And I do think that is a challenge that we, particularly as teachers in sports medicine, is a big challenge for us, because all of us at least have pivoted into mastery with holding a scope. So we're unconsciously competent of how to kind of navigate a scope, look backwards, turn, and do all these things. So it actually, to some degree, makes us not as good as teachers in arthroscopy, because to some degree, there are things that we forgot that we didn't know were a challenge for us in those first 50 reps. And so I see that, and so that's why I started using the entrustability language and the scales for my co-surgeons, is because you'd hear all this quote unquote garbage feedback when it'd be like, hey, this person just doesn't have it. Well, what does that mean? They don't have it. Like, well, I'm like, I want objectively, tell me, is it that they don't hold the scope well? Is it the progression is inefficient? Is it that they don't know what to ask for the next instrument? What is it? Because if it's, hey, they just don't have it as an arthroscopist, is it because they're on their learning curve and they're not quite there and they haven't made that pivot point yet? Which we all know where it is. Like all of a sudden you're scoping, you're like, oh, I know how to do this. I don't remember exactly when I learned how to do this, but I know how to do this. And so it makes it very, very challenging to kind of tease out what that turning point is, because, and that's why God bless you guys who, navigate having, residents PGY2, PGY3. Those are the hardest years because you have to be exceptionally patient through the curve, right? Which is, how do I get somebody from this to, hey, they can at least hold the scope and they're not making me dizzy or nauseous in the case. And everybody has that learning curve, but it's difficult as teachers to sort of walk people through that curve because we've done it so often. And so, that I think remains a particular challenge in sports medicine.
Yeah, I have one more question.
Yeah.
Excellent talk. A fellow 2007 alum. You guys can see how wonderful her career has been. Now, some of us are slower on our nerves. I was the worst basketball player in the history of UVA athletics. And I think a lot about the coaching that I received as an athlete, regardless of sport, right? And in our situation here at residents, fellows, it's like the coach also gets to play.
Yeah.
But I think the analogy still holds. So say all this as background and to ask the question, how much of the entrustability feedback has to be verbalized and written? Because so much of entrustability is Dr. Didek is letting me do this part of the case.
Mm-hmm.
I think he trusts me to do it as a two. And then when you start banging into the scope, and he's like, okay, let me take a spin. And totally with Dr. Brown, and he says, okay, take a look. And that is a cue that says I have done enough, well, this part of the case. Now I'm leading. How much of the paradigm has to shift that feedback versus the implied feedback or the sort of like, oh, okay, I was entrusted with this part, so I am entrusted.
Yeah, I mean, and it goes back and forth because it's not the same in every case. I think that's the point you're making, where it's very different. And it goes back to, I get semantics feedback from my faculty about this all the time when it comes to the O score, where they say, hey, there are times where, I absolutely don't need to be in the room, but then when I look at how I measure somebody, it says this person doesn't understand the risks. It's like, well, and they're like, how do I reconcile that where it says, I don't think this person's dangerous by any means, but, but maybe there are a few risks that they don't quite understand. And that's where it goes back to, the differential between like level 3, level 4, level 5, etc., which is that score can change vastly from case to case. And you as a trainee and also as a teacher may find, hey, like, I forgot this person doesn't know what's going on there. They haven't seen this yet. They haven't seen this complication yet. And it does then kind of alter your score a little bit when you're thinking about how do I actually score this person. For me, I always think about it when I'm watching fellows, I progress them through arthroplasty in a very systematic way. I say delta pec, humeral-sided work, glenoid-sided work. And glenoid-sided work is usually kind of third and last. And then even then, like I'll walk them through a case and then there'll be certain levels and you have to think about what's the complexity of that case. And so I may allow somebody who's doing a reverse for massive cuff tear to just kind of fly through stuff. But somebody who's got cuff tear arthropathy, where everything is contracted, the releases are a little bit more complicated, I may not necessarily trust you to do certain parts of that case. And it's not because of your skill set, it's because of the complexity of the case. And so I need to be able to give you that feedback to say, okay, maybe I don't want you doing the inferior glenoid release in this case. Or like, I may take the knife away from you, but I'm going to give it back to you. But I also have to articulate, there's a reason I'm taking this away is because there's a risk that you're aware of, but you have not seen that I'm trying to minimize you, falling into. And it's not because I don't trust you to do this successfully. I think that's a difference between how you take the knife away, but also tell them, look, like, I know you know how to do this, but today's not the day for you to, buzz the axillary nerve. Like, it's not the day. So, those are things that I'm still, evolving as a learner. I consider myself a medium autonomy attending. It's not a white glove case for the fellow, but like, I will absolutely be scrubbed over your shoulder and then backing away at times when I feel like you're comfortable. And that I think evolves over time because I like full control of my OR. So I acknowledge that. But those are things that's where risk tolerance as attendings also changes. Where's your risk tolerance as you get further along? And so more senior surgeons may have higher risk tolerance and really let somebody fly. And then a more junior surgeon may say, no, I need control over this. So. Any more questions? Okay. All right. How much time do I have on the other one? Exactly 45 minutes?
Yeah.
Okay.
How long is your other?
45 minutes.
45 minutes?
Yeah.
Yeah, we probably.
Stop until 5. Yes.
No, you can talk to some of the residents
Yeah.
who will stay for a bit, but
Mhm.
we have some people may be leaving. But before you start the second talk, I just want to thank you for being here and provide you with a lot of UVA Ortho swag, which I hope
I love it.
you'll wear because
Yeah, all my stuff is wearing out. I
Yeah,
can't
yeah.
every
So
single UVA shirt.
There's a UVA shirt, there's a UVA hat,
I
and
love it.
then sort of a little plaque to commemorate your visit here. So thank you.
Yeah, I appreciate it. All right.
Sure. Everybody's got to go, obviously go. So there'll be some people that have to leave, but we'll stay until you're done. Yeah. Same with the residents.
I'll fly through this, probably not, but I'll try. So I'll get into this talk so we can kind of get going. And then I ask people, please interrupt me, ask questions throughout. I think it will make it a little bit more interesting. This is a little bit more of a provocative talk. It's one I haven't given in a couple years. And I'm sensitive, particularly as an alumni here at UVA, as to some of the challenges that have been faced when it comes to discussions around women, minorities in different spaces. And so, for me, this talk has evolved, continues to evolve as the climate kind of changes for discussions in this way. And I also think what's been, remarkable over the last 5 years is there, we couldn't talk about a lot of these things for a while, or they fell on deaf ears. And then the ears became very open for a while. And then for some, those ears have closed. But the door has opened in a way that I think is very appreciative, where there are people who are still listening. And I think that's important to kind of continue to have those conversations, even if it's not as friendly of an environment as it used to be to have discussions around these areas. So, my disclosure related to this is I'm aware of many hats, which we kind of talked about. I'm a fellowship director. I'm also a member of our GME council or HSS. Research-wise, I'm the chair of our PROMS compliance committee, which is a committee that I created because we didn't have it. And then also our steering registry, from an equity and inclusion standpoint, I'm a member of our Culture and Inclusion Council at HSS, as well as our Health Equity Advisory Board Task Force. I'm a team physician for 2 professional sports that have a high population of women, minorities, LGBTQ athletes. And so, and then I have a busy clinical practice in sports medicine and shoulder surgery, primary revision surgery. I have high CNS insurance population, a large population of Medicare, some Medicaid, which many of my partners do not take. And I would say that I have an unusually high, though the numbers aren't published yet, higher than average population of women and minorities in my practice at HSS. And I say that because, in this talk, I'm talking about things through multiple personal lenses and multiple identities. A Black person in America, a woman in America, an immigrant in America, a woman in orthopedic, sports medicine, academic medicine, a Black person in orthopedic, sports medicine, academic medicine, and distinctly different, a Black woman in orthopedic, sports medicine, and academic medicine. And so that does influence my perspective on the importance of representation. But I also have a lot of blind spots. I have an advanced degree. I am a US citizen, for what that matters now. Cisgender, married, financially stable, and if I weren't in New York, considered potentially rich. Okay? And I'm also professionally backed by an internationally reputable healthcare brand. And so that brand is HSS, right? Which is, our Sports Medicine Institute is considered a world destination for professional athletes, et cetera. And really what we think about our reputation is, focus on, high demand athletes, basic science, clinical research, surgical innovation, individualized rehab strategies, and then people who are at the highest level of multiple international societies. These are kind of our three pillars below, which is Russ Warren, Tom Wikowitz, and Dave Alchuk, who's recently passed away this last summer. And then this is our teaching faculty, which is, we have 22 surgeons. It's, and actually 33 total surgeons, 40 sometimes, like if you actually include kind of the broader area in the tri-state area. And then here's our leadership tree. And so what you see is a diverse coalition by multiple measures. We have Riley Williams, who's our service chief. Our department is bigger than most orthopedic departments in general, and it's just sports medicine, orthopedic sports medicine. And then we have our division chairs who, come from diverse backgrounds. And then we have a Black woman who's our primary care sports medicine chief. She's actually parallel to Dr. Williams, not subordinate. Myself as the fellowship directors, and then you see we also have our research directors as well. And so you see a lot of diverse looking faces. And I would say that diverse coalition is an outlier in orthopedics and sports medicine. But why should we care, right? We do it well, supposedly. How do we get there? Why is it important? And so I want to talk a little bit about why representation matters, and then we'll dig in if time permits to the the other factors. Why does representation matter? It's like what we know is that because those who are underrepresented have less access to good care. You see this among ACL patients where there's a slightly higher proportion of white patients who undergo ACL reconstruction, and that discrepancy is particularly stark with Medicaid patients. And so among those who underwent ACL reconstruction, there's significant underrepresentation if they're a Black patient with Medicaid. Well, if you're a white patient with Medicaid, you probably actually had an equal likelihood of having an ACL reconstruction if you needed it, whether you had Medicaid or other private insurance. And then we see that consistently. Also, English-speaking patients are more likely to get an ACL reconstruction. Black and Hispanic patients have much longer surgical delays after ACL reconstruction, and they're less likely to undergo elective ACL revision compared to white patients. We know that lower income students are less likely to have a team physician. They're less likely, particularly if they are a lower income student that's Black or Hispanic, and they overall have worse access to medical care for their athletes. Our research is there is significant discrepancies in our research. Compared to the U.S. Census, orthopedic clinical trials have almost 20% more white applicants, almost 5% fewer Black applicants, almost 17% fewer Hispanic applicants, and 5% fewer Asian participants. For women, there is major discrepancy in how research looks at male versus female participants in medicine. Only about 39% of participants in the vast majority of research in the big three sports medicine journals have women. And most studies in sports medicine are actually isolated to just male athletes. So 70% of the high-level research studies from the top 6 sports medicine journals, between 2017 and 2021, had only male athletes, no female athletes whatsoever. Half of the population completely not represented in our research. And the thoughts behind that is because the availability of public data maybe is not as great. Also high percentage of male sports medicine clinicians and researchers, and then also potential some biases in the sports itself. Even when we think about concussion management in those studies, 40% of the studies that were used to make position statements for concussion consensus, which by the way, the highest rated concussion risk, which we're aware of, women's soccer players, right? 40% of those studies have no female participants whatsoever. So our literature is vastly underrepresenting women and minorities. And also if we think about representation, for me, physician representation is necessary to stem our failures in patient-athlete agency. What does that mean? How do we provide agency for our patients? You guys may all know this study because I always remember this is a study done at UVA. Right? Which is not the first one, which says that Black patients are significantly less likely to receive paid medicine in the ER. That study was out of Atlanta. This study, which says that 40% of first-year medical students at the University of Virginia think Black people have thicker skin and they have less sensitive nerve endings. That was a 2016 study that's only 10 years old. So, other things, D1 athletes, the medical staff are more likely to assume a Black athlete feels less pain than white athletes, particularly if they are a poor Black athlete. They think that they feel less pain. And not too long ago, the NFL actually only just recently, 3 or 4 years ago, halted race norming. So everything that came out from brain injuries and CTE, there were $1 billion payouts, a settlement for those former players with traumatic brain injuries. And what they used to do is say, what was the cognitive norm for the Black athletes would be lower, so they receive less money. That was 2021 that stopped. So we're really not that far off if we think about how representation and is affected by our failures in agency. Other factors. Black athletes are more likely to have negative descriptors in their medical record. They're more likely to say they refused care, they were non-adherent, non-compliant, agitated. They have 5 times more negative notes, or usually 5 additional negative notes per 100 patients than white patients. 300 times more likely to be described as rude, 20 times more likely to be described as belligerent or uncooperative, more likely to have a negative emotional tone or greater use of social dominance language in the medical record, permanent records in how patients are seen in perpetuity. And then what about gender bias? Do we see it? Yeah, absolutely. Do you guys remember these articles? I remember seeing this for a while. It was all over social media, which is, women surgeons are better or just as good. They had all these articles, Guardian, Stat, Wall Street Journals. The female doctors make better surgeons than male doctors. Where did that literature come from? So this was the JAMA follow-up study that looked at surgeon sex and long-term post-operative outcomes among patients undergoing surgery. And if you tease it out, so what did they say? They said, okay, patients, whether they're male or female, when treated by male surgeons, were more likely to be readmitted within 90 days, within a year, more likely to experience complications within 90 days. Female patients in particular had significantly worse outcomes and higher rates of adverse postoperative events when treated by a male surgeon. And so how that was interpreted was women surgeons were better, just as good. We can do it. This is the prior study that looked a little bit more actually, same group. And they noticed that kind of outcome discordance was only significant if the surgeon was male, meaning that there were worse outcomes for female patients when they were treated by a male surgeon. Male patients did not have that issue when they were treated by female surgeons. So how I've taken that, instead of saying, hey, women surgeons are just as good, maybe better, what we really should be thinking about is why are male surgeons' outcomes so much worse for women? So why are they worse? It's not quite clear. Implicit bias may play a role. They looked at this and say maybe male physicians may underappreciate female symptom severity. Female patients may report less postoperative pain to male physicians because they don't feel as comfortable, and so that could lead to an incomplete exam. But there are other things, and Dr. Dacus, we talked about this last night, so I dug in a little bit, and you're right. This is a study that looked at, margin for error is narrower for female surgeons. There are fewer outliers. And so women surgeons received a mean of 5 fewer referrals per month than male surgeons. So 30% of their new patient referrals, 5 is less than male surgeons. And that discrepancy is worse as you become more senior. So as you're a more senior male surgeon, you have 11 more referrals per month than a senior female surgeon. So it's not related to level of experience. That discrepancy becomes wider. And then when you think about unexpected complications or unexpected successes, after an unexpected death, a female surgeon, her referral patterns drop by 54%, while there's minimal effect on male surgeons. If a patient unexpectedly does well, hey, we didn't think that guy was going to make it, you saved their life. 0 effect on the referral patterns for female surgeons. Male surgeons are the savior, their referral patterns improve. And so that potentially means that female surgeons, we have a narrow window to be successful, while outliers are rarely penalized among male surgeons. So, gender bias is similar. We talked about biases in pain. How people perceive pain is different based on male or female sex. When we talk about visible pain demonstration, a few studies have shown that, women are perceived to have less pain than men, but they're more likely to be considered, a pain catastrophizing, or told that they're exaggerating their pain when they demonstrate visible pain. This was an interesting study. They looked at video clips. This was actually a chronic shoulder pain, and estimating a patient's pain intensity based on how their face looked when they underwent a shoulder exam, and the reviews. Or this is just laypersons. This is not specifically physicians that did these video assessments. And perceivers underestimated female patients' pain compared to male patients' pain. They were more likely to prescribe male patients pain medicine, and they were more likely to prescribe female patients psychotherapy. So, for their pain. Women are less likely to receive analgesia, less likely to receive opiates despite similar pain scores. And also, when male patients present with pain, for example, knee pain, they're more likely to be referred to an orthopedic surgeon, to manage their orthopedic condition due to perceived higher activity or demands for a male surgeon, with the thought that, demands for a male patient, with the thought that if a man is presenting with pain, he obviously has a more serious condition, so he more likely warrants surgical intervention than, say, a female patient. And so, this is how we lost the narrative, basically, So, this is a New York Times study talks about women are calling out medical gaslighting, which is where physicians or providers blame a patient's symptoms on their psychological factors. And it's been stated that we dismiss women's health concerns because of the misogynistic stereotypes that women are irrational or hysterical. The UN has stated that over 90% of men and women are globally biased against women, so men and women. And then if we also talk about patient agency and our failure here, I'd be remiss in the sports world to not talk about Larry Nassar, where this continued in perpetuity, where we were not advocate for our patients, particularly our female athletes who, expressed concerns about his behavior and his actions, and this was dismissed. So, and a lot of that weighs heavy on me, as a Black woman, but also for a professional team physician for a team that is predominantly Black women, LGBT women, extremely marginalized women in general. And, there are specific challenges that we see for the female Black athletes. Serena Williams has shared her kind of childhood story, and that's somebody high income, high level of success, and she almost died after childbirth because she felt that her concerns were not being, articulated to the physician staff. And, when we even think about the highest level, so these are the four gold medalists from the 4x100 relay team. And 3 of 4 of them have demonstrated that they had significant complications related to childbirth. We know that the Black maternal mortality rate is substantially higher in the US than any other demographic. And actually, Tori Bowie, I think she was only 28. She died at home from childbirth complications pursuing preeclampsia. She didn't have access to care. So even if you're at the highest level of success, these are real challenges that are faced. And so if we are not agents for our patients, then there's mistrust among our patients and our athletes. And we also know that stress negatively affects outcomes, particularly for Black men and Black women. And so that can increase their potential burden of health overall. Black patients feel that they may have, and both, Black, Hispanic, Asian, and American Indian patients feel they have to modify their mindset and the way they look to stave off potential mistreatment during their healthcare visits. And the majority of, Black, Hispanic, American Indian, and Asian adults report less than 50% of the healthcare visits were with a provider that looked like them. And when they do have somebody who looks like them, they're more likely to say that the doctor explained things in a way that they could understand. They were involved in their decision making. They understood or respected their cultural values, or asked them about their work, housing, other stressors. And this is in contrast to, 73% of white adults say that more than half of their visits were with a white physician. So those allow for some concordant care. And particularly for orthopedics, Black patients are 6 times more likely to experience difficulty related to their orthopedic surgeon. They're 14 times more likely to perceive bias from their orthopedic surgeon. They're more likely to express an importance in having a racial concordant surgeon than white patients. And really, relatively, from a gender standpoint, that was less important for both male and female patients. But there is overall a gender preference for many patients. Women are more likely to say they prefer treatment by a female doctor, while men, it didn't matter as much. So about 46% of women prefer a female doctor. While only 23% of men prefer a male doctor. So is the answer that women and minorities should only receive care from women and minority surgeons? No. So, and this is a JAMA article that sort of goes along with that, which is, you can increase the number of Black physicians, which makes it more likely for somebody to see somebody that they easily identify with, connect with, but that's not to say that racially concordant care is the way. What it should tell us is that healthcare to minority patients, we can utilize our minority physicians to understand some of the challenges that our minority patients face, but ultimately we need to improve cultural mindfulness for all of our physicians so that we're able to care for a diverse patient population, even if somebody's not of the same gender or of the same race overall. It should not fall to say, hey, go take care of your people. Because frankly, there are just not enough of us to do that. So if we think about the demographics of our patients and our physicians, here's our US population. By 2050, over half of the US population will be persons of color. So, and white persons would be the minority. Among our NCAA athletes, it's about 30% minority. It's split about 50-50 females to 47%. When you're talking about D1 athletes, and then 35% minorities among D1 athletes. And then obviously in terms of distribution of certain sports. Football is over half persons of color. Basketball is over 60% persons of color. And same for women basketball, 50% persons of color. So, overrepresented compared to the US population. Then when you get to the professional level, there is a greater kind of change in the representation of persons of color, particularly for NBA, NFL, Major League Soccer, and women's basketball. And when we compare that, however, to our population, when we think about the U.S. population versus orthopedics, this is AOS members versus the U.S. population. White physicians are overrepresented, Black physicians are underrepresented, Hispanic physicians are underrepresented, and Asian physicians are approximately neutrally represented. When we look at ABOS diplomates, there's a bigger discrepancy in orthopedics. So this is 2023, so we've made strides, but we haven't made that many strides. It's still 85% male compared to 8% female, but some non-disclosing. About 16% persons of color, of which Black is less than 2%, Asians about 7%, Hispanics about 2%. We are seeing some greater trends in terms of female, diverse, underrepresented minority faculty in orthopedics. So there's some things that are changing, particularly among female faculty, which is the blue line. Diverse faculty includes both underrepresented and diverse faculty, but you can see the line is actually continuing to trend downward in terms of underrepresented minorities, which is Black, Hispanic, American, Indian overall. And then we see that most substantially within sports medicine. So even within sports medicine, we have less than average female representation than AOS. So 6.5% of AOS members are female. 4% of division chiefs are female, 86% are white. Fellowship directors, this is actually not updated since I became the fellowship director, so we may be at 2% now instead of 1%, but to be determined. And then that discrepancy continues as we think about, as people progress in specialties. So as we go, in any specialty in medicine, the vast majority remain male, practicing physicians, and as you get down to orthopedic surgery, this is separate from AOS guidelines. About 7% of orthopedic surgeons are female. And from a minority standpoint, there continues to be a trickle down as we get from all specialties, where about 5.7% of all specialties are Black physicians, but that drops down to 3.5% of orthopedic sports medicine physicians. Same discrepancy with Asian and Hispanic surgeons. And then when we talk about, on the professional side, if you're an NCAA Power 5 conference like the ACC, team orthopedic surgeons are almost 1,500 times more likely to be male. Only 18 team physicians overall are identified as female orthopedic surgeons. And we see it at, at the professional level, orthopedic team physicians make up only 4% of the pro team physicians. And that discrepancy is particularly stark when we think about those population differences. So the NBA is the highest minority person of color representation among its team physicians, but compare that to 83% of the athletes are persons of color. So that remains a huge discrepancy. And the NFL has the lowest minority representation, 11%, despite having the second highest representation at 74% persons of color. And so ultimately, we know that women and minority physicians are progressively underrepresented in sports surgery, sports medicine, among sports medicine leadership, and among NCAA and professional team physicians. And so, what factors affect some of that representation? Well, there are leaks throughout. So I've described this, and I'll run through this pretty quickly because, we know that this is a complicated milieu when we talk about how people get into orthopedics and how people get through orthopedics. But a lot of it is finding the door into orthopedics, which I do think we've done a better job at, getting people to see the value of going to orthopedics as persons of color, of women. Right now, where we continue to struggle is getting through the door. And then finding that inclusive or equitable environment on the other side. So for many of that, some of those pipeline leaks start in medical school. It's not the case for women anymore. The women since at least 2019 have been the majority of medical students. 56% of medical students right now are women. And so for women, the pipeline leaks start after they get through medical school. We start seeing over half of medical students are women. Right now, we hover and continue to hover about 15% of orthopedic residents are women, and only 7% of AOS fellows, board certified surgeons, are women. And so what does that mean? How does that factor into things? So there becomes, women are 50% of the population, but they become significantly minoritized when they get into orthopedic residency. What does that mean? So minoritization is where a social group is devalued in society and given less access to its resources, how they're represented, the degree of access, and how that access is rationalized. And so it's similar to being marginalized, but now you're in a population where all of a sudden I'm one of few, and that can affect perceptions, progression throughout because the access is less. And so, we have had this kind of stagnation for many years, but we haven't been able to crack this 20% metric for female residents. There's been a slow climb to get to 15%. And so this study came out in 2021. Well, there's some tide changes that were coming through, and it said in order to receive gender parity, and gender parity was 36%. That was 36% of women in orthopedic surgery, 217 years. Things have changed. There's actually been some exponential growth in gender matching in the recent years. And so in the past 15 years, and as we really sort of head into 2025, those numbers have improved. So we may actually receive gender parity in 16 years to reach that 36%. So there's some bright sides there, but there remains significant pessimism on the race side. There are 0 parity studies in race and ethnicity in orthopedics. And again, some of that is a moving target. It's hard to tease that out compared to population. But Americans also aren't very optimistic anymore about it. So they're not optimistic about achieving racial equality. The vast majority feel that it's not too likely or only somewhat likely that we achieve racial equality in the US. And that goes along with the data for minorities, and the pipeline to sports medicine and orthopedic surgery. So the number of underrepresented minority matriculants have not kept pace with gains in terms of medical school matriculants. Even though the number of slots have increased by 25%, we have not seen any change. So in 1980, the number of minorities among medical matriculants was 11%. In 2016, it was 13%. So we didn't make many strides from that standpoint. And in particular, if we look at Black students as an example, they have significantly lower rates of being admitted to medical school. So their acceptance rate is only 35% compared to all other demographics. And we have yet to really kind of crack that 10% barrier for underrepresented minorities in orthopedic surgery. And there have been years where there have been significant dips in that number as well. And we're only just kind of sort of climbing back. And even as of 2019, we had a lower percentage of minorities compared to when we had in 2002. And so why are we having some of those challenges? And I think some of the reason things have changed recently, we've seen this exponential growth, is culture. So, historically, a big deterrent for female medical students to pursue surgical residency was this perception it was a boys' club. It had nothing to do with family concerns or lifestyle concerns for surgery. It was this perception of, hey, I'm not welcome there. So I do think as we have sort of leaned into demonstrating that, orthopedics is a field that it can be welcoming for women if we provide the resources to be welcoming, we have seen this increase in female applicants being interested in orthopedics. And so, culture in the surgical work environment was a deterrent for both men and women. But really that kind of presence of supposed male domination in surgery was the bigger deterrent for women. And so providing that kind of culture shift perhaps will continue to make some changes. But there's still remain concerns about perceived discrimination and inequity. And those are both real and perceived, and that's the most commonly reported deterrent. And we do know that exposure, however, can help interest in, for women in orthopedics, but it's not enough to overcome those deterrents because of a lack of female role models, the orthopedic stereotype in that male-dominated workplace. And these, one-off events, which we like to champion often, which is to have an event where we have a bunch of students come in and say, orthopedics is great, you should go into orthopedics. They're not enough. They're not enough to kind of foster and continue that interest in orthopedics. They don't help. For race, it's a little bit more complicated. There's discouragement about fit within orthopedics, the difficulty of the match, the competitiveness. There is also a lack of that early exposure, early mentorship and sponsorship as well. A lack of minority faculty, which then trickles down and makes it so that people don't see themselves in the faculty in the field. And so that makes it harder for people to want to pursue. And then we do know that there are some challenges. This is a study that looked at barriers for recruitment. However you feel about the step one, which I have a very, I would say, evolved position about the utility of the step one, we do know that, there was inherent bias when it comes to race in terms of selection and scoring for step one, AOA status, and then med student performance evaluation. We've essentially done away with step one scoring, and so we do look at AOA status and med student evaluations, which probably have even more subjectivity in them, and we've eliminated an objective metric, which perhaps has some downstream effects, and we're now just understanding that we may not have helped people by eliminating the one objective metric that had some bias, and leaning more into the subjective metrics. Yeah.
What I don't know as much about that in terms of the step one. Give a little background on what bias was present in the step one scoring evaluation.
Yeah, a lot of it was the amount of resources available for people to study where there's a discrepancy. So and the resources to prepare people to study. So if you think about who helped you think about how to prepare for step one, right? It was other residents or other medical students. It was different teachers. It was people who looked like you who said, this is how you do well at step one. Also, what was your foundational learning coming out of undergrad? And so some of that foundational learning, there can be some cracks along the way in terms of how you prepared for courses, what schools you went to, what your overall, score was coming into orthopedics, your testing ability. And so then we would see now that those are things that propagated when it came down to preparation for step one, or if somebody did not have explicit resources to say, here's how you ace step one, these are the books you read, this is what you need to buy, because there are also socioeconomic challenges faced. And so that perpetuated significantly lower step one scores compared to other types of applicants. Yes.
But that called over though for any standardized testing, SAT, for instance, any of the large standardized testing, and it has access through internet enabled better things so that you're not always having to buy a test. Like, there's a lot more information available in a more democratic form. Has that then helped some of that, or is that still?
I don't know.
Democratic meaning,
Yeah.
not political, but
Yeah, access to the
access to the
resources.
resources.
I don't know, but I would guess no to some degree, because it still comes down to who are your mentors and your sponsors. And if there's a dearth of mentors or sponsors telling you how to prepare effectively, you're not going to do as well. If you think about how we learn in medical school, right? Most people come and say, I'm going to use the same strategies I used to get here. I'm going to read the same way I did. It worked for me. We all know there's a pivot, right? There's somebody telling you that you're drinking from a fire hose. You have to learn a certain way to be successful. We know in particular that step one, you can't learn all of medicine by the time you take the step one test. You have to learn how to take the test. So who's telling our medical students how to take the test? And a lot of it is that kind of coaching, and we do it, Vegas and I have been on, panels where we've talked to people about how to prepare. And the challenge is, we used to have, a metric that told us, hey, this person's got a 250. They're, by all metrics, they're qualified. And we didn't focus on some of the more subjective measures, how they did on rotations, how they perceived on rotations. And so to some degree, people could be accepted based on some of the metrics, kind of thrown away some of those metrics. And so with step one being pass fail, We've pushed much of that to step 2. And so people maybe are still not getting guidance on how to prepare for step 2. We've leaned more into the med student performance evaluation, which includes measures of how somebody's perceived at various different rotations. And so that can perpetuate different types of implicit bias, and make some of those challenges more explicit. Yeah.
Are there research efforts going into study now, like how sort of find the MSPs pre and post step 1?
I don't know if there are explicit studies. I know Selena Poon has wanted to look into that. The challenge is access to that data.
Right.
And so, it's very difficult to have that data. NBME is very, very protective of the data that's available. So being able to tease that out, how do you see all that information? How do you tease out something that's very objective and subjective in general? And so overall, underrepresented minority applicants have significant, yeah. Oh, bye. Sorry, I'll wrap it up in a few more minutes because I know I got 7 more minutes, and so they're accepted at much lower rates than white and Asian applicants, and that's even for controlling for academic metrics. So that was her work that, she took a significant amount of heat to publish a study in core. If you talk with her about it, she's a great person to talk about objective measures of how race and gender affect performance, and frankly, NBME wanted her to retract this paper from core because it really demonstrated that even after you control for those academic metrics, AOA status, step 1, step 2, volunteer research and work experience, underrepresented minority applicants are accepted in orthopedics at a much lower rate. So that speaks to there are intrinsic challenges. Does anybody who's still here, do anybody know what affinity bias is? Can you tell me what affinity bias is?
So affinity bias is, a person is drawn to people who have similar interests, similar backgrounds, look the same. I think.
Exactly. Yeah. And so a lot of that challenge is that, and that's one area that's difficult to measure. So sometimes it's somebody who looks like you. Sometimes they're like, oh, you went to UVA too. I kind of like that person a little bit more. That's affinity bias, And it's difficult to quantify that to some degree, which is you say, hey, that person reminds me of myself. Their training experience was different. They grew up in the same area I grew up. So I intrinsically like that person a little bit more. And that's where I think it's not just race and gender, because you can have affinity to somebody based on race or gender. It is that kind of perpetuity of a certain type. That's why I think to some degree we see a certain type in orthopedics, and as we see more people who look like ourselves, then ideally we can have more exponential growth in the different types of people in orthopedics who have different backgrounds and experiences. But really I would say that the main challenges that we're seeing is, what's that inclusive or equitable environment on the other side? And this is where I think we're still really struggling. When we think about, male physicians have a strong preference for referring patients to male surgeons, so we still see it on the practice side. Women in academic medicine, they have equal feelings of being engaged or enthusiastic about their work, but even though they have equal leadership aspirations, they don't feel as confident about their potential for career growth. They feel that there's lower gender equity. They're less likely to believe their institution kind of aligns with their goals, particularly for addressing diversity issues. And they also feel like their institutions have less congruence with their own values and those as well. Particularly in orthopedics, which I hope we continue to get better at this, when we look at kind of women reporting disrespect based on their gender, the worst offender is orthopedics, compared to other fields. About 25% of women in orthopedics have felt they received disrespect based on their gender. We looked at what does gender justice in academic medicine look like, and it's addressing some of these barriers, which we articulated as sexual harassment and discrimination, lack of visibility, decreased mental wellness, disproportionate family care responsibilities, and difficulty with professional advancement. And that's mirrored on the minority side, where about half of underrepresented minorities in academic medicine felt that they experienced racial ethnic discrimination by a superior or colleague, and they had significantly lower career satisfaction despite other faculties, despite having similar salaries, similar number of publications, similar academic rank. And if you even take a step back and we talk about in the workplace, it's a study that Catalyst did. And so they showed that women are more likely to report feeling on guard at work because of anticipated gender bias. Women of color feel more on guard based on both gender and racial bias. And then most distinctly, if you think about talent drain, those who were on guard, so 89% of those people who felt on guard about perceived gender bias or racial bias in their workplace, they still had a strong drive to succeed and be successful. But, they felt, they couldn't achieve it. So that contributed to a loss of talent or a talent drain in those institutions where they said, I just don't feel like I can, be successful. And they often left those institutions, and so, some of those factors that, force us against diversification is that, denial of those implicit biases. And I think people in this room have said it or heard it. And often it's well-meaning, which is I don't see color or gender. Or we say, hey, you know what? We hired a woman or a minority in our departments and she's done great, right? She's successful. So we don't have a bias problem. It's that person is successful. And so what that does, it minimizes for the women and minorities, particularly even the ones who are successful, their concerns related to interpersonal or institutional discrimination, because it's perceived we have a woman, we have a minority, we have several, we don't have biased policies. This is not a problem at our institution. And then similarly, when we think about conflicts avoidance, so this even goes back to what we discussed about, feedback for residents, right? There's this desire to protect women and minorities from negative feedback. So their mentors, who may be well-meaning, may hold back critical feedback out of a fear that, hey, maybe it'll be received as biased, or maybe I'm just not going to say anything. And that's a slippery slope. That's a dangerous, place that we are currently. And then there's also that lack of institutional support. Many trainings are not designed to help people navigate their own positions at the margins of their different departments. And so ultimately, all of those things come together and it results in under-resourcing of needed support for career advancement, for already hyper-isolated, hyper-visible, minoritized faculty. So it does become a significant challenge. And some of that challenge is also the minority tax. So, Rashard, do you know what the minority tax is?
Yes, you when you're the only one, you're asked to do everything that needs to be involved for an inclusive environment. So it's
Yeah. And so too, and you're also experiencing bias and discrimination, whether it's coming from patients or colleagues at times, that you may be the only one in your department, so you have increased isolation, and you have also less access to mentorship and job advancement opportunities while taking on the additional burden of kind of carrying the torch for all diverse people, not just your own diverse metrics. So, how does that, I like to use the slide to kind of explain it a little bit, and so when you think about how it propagates down the pipeline is, you have, a minoritized medical student, whether a woman or a minority or LGBTQ2 or, and they say, hey, I'd really like advice and mentorship on a career in orthopedics. I'm very interested in orthopedics. And they go to a faculty member who's in a position of authority. Very often they're more likely to be male and or white. And that person says, absolutely, let me direct you to my minority colleague to provide advice on how to be most helpful for you. And so they ask them, hey, Dr. X, I've got a student that could really benefit from your mentorship. Sure, right? What that kind of person in senior leadership doesn't realize is that person, Dr. X, has said yes to that student. Somebody else has asked them, they said, sure. And then the student has come to them directly and said, I'd really like your advice and mentorship on a career in orthopedics. And then also, department leadership says, hey, can you oversee our diversity initiatives? You're going to have no career directives, budget, administrative support, metrics for success, and it also doesn't count towards your academic achievement, but think about it. So it does kind of contribute to this burden, but also subtly what it does is that first student who asked the person in senior leadership for support, advocacy, mentorship, that doctor said, my work is done here. I have provided them. Yeah, I provided them a resource, but I guess that person wasn't interested. And so it does contribute to some missed opportunities for mentorship. And so I will very briefly go through this because I know we are over. And so how do we go from here in 2026 and beyond? And so this is the only slide you'll see me that says DEI. Right, and so this is a great article that came out January 23rd of 2025, shortly after our president demonstrated that he was going to ban the term DEI from everything and anything involving kind of funding. And so that kind of put things in a bit of a tailspin. So this was a great article. I recommend it's by Lily Zhang, and she talks about a new framework around fairness, access, inclusion, and representation. And this book is on my list. This book actually published last week. I encourage it because I've read a little bit of her work, but she talks about the FAIR framework, which is stands for, how do we look about outcomes? Everyone deserves the experience. They deserve fairness. They deserve access to products, service, and environments. They deserve to feel included. They deserve to feel represented. It doesn't have to be just isolated to a Black person, an Asian person, a woman. It's everybody. There are different factors that allow for people to be minoritized or not feel represented, and we all deserve that. And so if we think about it from a refocused lens, when I think about, okay, back to those first slides, how did we get there? The HSS legacy, if you think about, here are the champions for our current leadership structure, and they all look a certain way. But, legacy begets legacy, which is, many of those people who are still around have been champions, supporters, advocates. They opened the doors for people in this leadership structure. And so it created a culture of inclusion where we said, we're all excellent. We're all going to be champions for each other. I didn't put this person at the top because they look a certain way. I put them at the top because they are excellent. And they are going to continue to hire excellent people. And so that has created a more organic way to have a diverse coalition. And so I'll skip through all this because this is an essential, and I can share these slides with people where we really talk about you want to have an equitable, diverse workplace, you want clear expectations for leadership, access, and opportunities to develop and advance, and then provide mentorship and sponsorship, particularly for early minoritized faculty. And ultimately, when we think about all of those things, underrepresentation, we know it perpetuates equity in research and patient care for women and minorities. We know that increasing the numbers of diverse surgeons can improve outcomes for our patients, but it also doesn't abdicate our white and male surgeons from providing equitable and excellent care. That leaky pipeline exists. Some things are getting better, but we do know that it worsens the leadership role obtained. And so if we think about to be successful, and so particularly for me, for women and minorities in orthopedics and sports medicine, we need an equitable workplace and diverse workplace environment, clear expectations of our role and a path for advancement, and then also those opportunities for advancement and leadership. Thank you. Ooh, sorry. 107 slides.
It keeps getting longer.
Yeah.
Really
Thank you,
appreciate you coming. Thanks a lot. Thanks for all this you could say. Yeah.
It's late. I was actually going to probably